So welcome everyone to the second of the Senior Clinician Network Forums. It's great to be able to be here and help you out today with just the information that's coming through. Technology is our best friend at the moment in these times, but also a challenge. I think we'll probably get through it quite well today. We will be on time, which is a good start, and we'll allow enough time for questions. Claire Lynn will be moderating today, and she'll determine the questions and who answers them. I just want to give you a little bit of an update on what's happening with Coho. And in the spirit of coordination and collaboration, we've made some partnerships since we last spoke. We've got David and Werner working with the directors in the dental hospital, and then we have each one of the other team working in the regional offices. So we've got Claire working in the north with Amy, Ruth working in the east with Nick, Katie working in the south with Jenny, and Ben working in the west with Melissa. So that will provide each of you with a direct line to the Coho team. So don't be shy about connecting with the team. And I will I'll hand over to Ruth, who'll be running today's forum. So over to you, Ruth, and I'll come back in at the end to say farewell.
Thanks, Martin. Welcome, fellow senior clinicians. Thank you. Thank you for carving out this time to be here. As agency senior dentist myself, I know how hard it can be, that juggling of admin time and clinical responsibilities. So our coming together is valuable. We are a public service through the state, hospital and 50 agencies, and we wish to strengthen these connections so that we can support each other in our work as clinical leads and share knowledge and resources from DHSV and around the state. So a lot of shared learning and support. So thanks for being here. Together we learn from each other's experiences and then can contribute more to our individual workplaces. So you asked for a punctual start and a focused topic. We have listened, and please feel free to provide constructive feedback again at the end so we can give you what you need most out of these meetings. There is a questions area in the event, and we'll endeavor to answer as much as we can at the end. We have 3 panelists speaking, followed by the Q&A session for the second half, so you will have ample time to ask questions and have some answers. The forum, the Q&A that was sent out after last forum was well received, so we'll continue with that, and you should receive that sometime next week once we collate all the questions and answers. So today our focus is on the challenges of treating the child patient. Much of what is reflected in the high number of referrals that we get for GA at the dental hospitals, and then the ensuing long wait lists and increasing disease in the interim. It is possible that some people feel the only way is GA for managing these children, and it is challenging to treat them in the chair. But today we revisit this idea and find ways to seek more timely care for these patients through other pathways. Our speakers today are Dr. Daniel Andreasen Cocker. He is the head of specialist periodontics at the hospital and will speak on preventable hospital admissions. We have Dr. Katie Theodore, a dentist in special needs and part of the Coho team, and she'll be speaking on stabilization in the interim time, so the need to know info on silver diamine fluoride. And you'll have myself at the end finishing up with the opportunities for relative analgesia. I will start the forum off with an acknowledgement to country. In the spirit of reconciliation, DHSV acknowledges the traditional custodians of the land throughout Australia and their connection to the land, sea and community. We pay our respects to their elders, past, present, and extend that respect to all Aboriginal and Torres Strait Islander people today. So I will hand over to Daniel now to speak about the new PEDS referral process designed to provide more timely care to those who need it. Thanks, Daniel. Over to you.
All right. Good morning, everyone. If we can just jump along to the next slide, thanks. Oh, there we go. Yeah, so basically, I'm just going to have a quick update on some of the ways we're working on reducing preventable hospital admissions. If we can jump along to the next one, thanks. And this really needs to happen at multiple points. So we need to target all parts of healthcare delivery, particularly important during our current coronavirus disruptions. This is from at community level prevention, primary healthcare prevention, also how we deliver primary healthcare, then how do we deliver specialist healthcare, and how do we stop these kids from coming back through the cycle and starting all this again. So that for us, so I obviously get involved at the specialist healthcare delivery level, but how parents come in and what expectations they have before they arrive even to see me can have quite a big effect on what they would accept. And that might be some communication they've received at the local clinic, and that might be intentional or completely unintentional communication. And in addition to this, we're working on some reducing children and teenagers requiring repeat hospitalizations. The dental hospital does quite well on this data compared to other facilities that publish their data, but we still have a lot of improvement that we can make. If we can jump along to the next one, thanks, Curtis. So basically, of the children where the referral specifically says the child requires treatment under general anaesthetic, about 20% of them, so 1 in 5, do not get treated with a general anaesthetic. We manage them in the specialist department through often a combination of methods. Minimal intervention or minimally invasive dentistry principles is a big one, and obviously behaviour management, and a big part of that is often nitrous oxide sedation. And next slide, thanks. So the first thing is there's a new referral form that's been sent out, so hopefully everyone has that loaded onto their titanium. So if you could just have a look at that and when you get a chance and update, look through and see that, familiarise yourself with what it now is asking. But one of the major changes is please do not give out or fill out that GA medical form. And the reason for that is it gives a lot of parents the impression they're on a waiting list for a general anaesthetic, and a general anaesthetic is the only option for their child, whereas they're actually on a waiting list to be assessed by a specialist and have a range of options discussed and decided upon. Yes, a lot of them will require a general anaesthetic, but not all of them. And the other thing is probably important to do is not to say that we are definitely going to give them a general anaesthetic, because that just makes, from our point of view, hard to work with parents considering what other options are actually available and what might work, and therefore reaching a consensus with the parent and gaining informed consent to undertake alternative options. Next slide, thanks. So really, at the end of the day, the behaviour management technique for that child, once you've made that referral, whether it's pharmacological or non-pharmacological, is a decision between the patient, parent and the specialist. So, one thing I've heard a lot of is dentists or therapists saying, well, when we make a referral, and the parent says, what are you going to do differently? Well, what's the dental hospital going to do differently? And you do need to have a bit of an answer. So you can say that there's a range of treatment options. It might require some nitrous sedation or general anaesthetic. So you can mention that as an option, but not to say that that's what we're going to do, and that's the only option. Next slide as well. The other thing is there's a strong perception from parents that we give a GA, they rock up on the day and they're going to have their treatment at the first appointment. And the main reason you can't do this is we need to plan it. We need to work out what's the most appropriate treatment method, as well as actual treatment, as in what are we going to do with each tooth. We need to work out how long it's going to take. We need to work out what alternatives. And then obviously there's the whole consent process, which can become quite complex for some parents and patients. An equivalent of that would be if you went to your GP and you had a tonsil infection, and then you go to your ENT surgeon, you know, they refer you to an ENT surgeon, and on the day of the operation, they have to assess if the tonsil is actually the most suitable treatment. And then the parent won't have time to consider any risks or alternatives for that procedure. And the ENT surgeon also might need to assess whether something like the adenoids need to be removed as well. So it is actually a lot more complex. And so just making parents aware that the first visit is going to be a consultation also can be helpful as well if that discussion comes up. Next slide, thanks. So we also, the other major change is coming down to prevention. So we know that we have a huge fail to return rate for kids following treatment. It's about 30 to 40%. So we basically know that we need to target some of this prevention before treatment. The other aspect of this is, unfortunately, our waiting lists are looking a bit worse in the last few months, and so kids are going to be on the waiting list for longer. So getting them to a stable position before we actually do the surgical work is really important. So if they're getting their preventative care while they're on the waiting list, we can stop things getting worse, as well as educate them so that after their treatment, hopefully we get less recurrent disease. So the request is that when patients are referred, that we're seeing that they are then seen in your clinic, because it's easier for them to see you than it is to see us, every 3 months. If they come in and they haven't been doing that, well, we can get them to do that with us, but it's much less efficient that way. And also that means that if they've gone and changed a lot of their risk factors before we even see them, then we know we can manage them so much better. And next one, thanks. The other thing that you might start seeing coming through is another project we've got with one of the specialists, which is also working on the same prevention, is they might return to your clinic with a letter requesting some oral health education sessions, ideally with an oral health educator, but can be with a therapist or a hygienist if there are no educators in your particular clinics. And then there would be a short survey. So we're just trying to play around with a little bit with some ideas on improving this prevention around the general anaesthetic. So that might be something that you'll start seeing turning up in with patients in the next little while as well. All right, thank you very much. Next, I think we've got Katie coming to talk to you about the silver diamine fluoride.
Thanks very much, Dan, and thank you everyone for listening to the presentation this morning. I'm going to talk to you about the silver fluoride, and I hope what you can take away from this short presentation is that this is a procedure that you're able to teach yourself how to do. It doesn't require any extra training. You just have to be educated, educate yourself on the product and how it's used, and hopefully we can get everybody comfortable with its use across the state, because it's going to be a really important part of keeping children managed while they're waiting for specialist care, particularly, but not just children, special needs clients as well. Thanks, Curtis. So I've got 10 minutes and 10 slides to try and get through, and these are what I hope you'll take away, is what safety considerations need to be made, how to discuss silver fluoride as an option with parents and care people, and the recommended workflow and protocol and procedure for use, which adverse effects you would expect and contraindications for use. And then I've got a list of resources at the end for your reference. Thanks, Curtis. There's a few different options of products for silver fluoride use. I'm going to be speaking mainly about Riva Star because it's the one that I'm most familiar with using. So in the product picture there, it comes in a tray We keep it refrigerated at the hospital. There's questions about how important refrigeration is. There's capsules that are not mixed in the machine, which I've got a mind blank currently about what's it called. It doesn't need to be shaken or anything. It's just a capsule that has a foil top, and you pierce it with a micro brush and apply the product directly to the teeth and lesions. It's a colorless liquid. This particular formulation is very high in ammonia, so it has quite a strong smell, which sometimes I keep suction over the mouth when I'm using it to distract a child or an adult that I'm using it on, to not have to deal so much with the smell of ammonia. The second chemical that we put on afterwards is potassium iodide, and that was designed to help produce staining that the gray of the silver produces on the tooth. What we find, though, is that when, because the product is marketed as a desensitization agent, similarly to Durafat, if you put it on a healthy tooth structure, you can reduce the staining on a healthy tooth by adding the potassium iodide afterwards. But if you're putting it on caries for caries arrest, then it doesn't prevent the darkening of the lesion that is a sort of naturally occurring part of caries arrest. Thanks, Curtis. We'll jump to the next slide. The main things about environmental safety is that it's a strong marine pollutant, so we're trying to avoid the actual substance going up into the suction or down the drain. So when you're finished using the capsule, my recommendation would be to wrap it in gauze and chuck it in the bin. And we do recommend that we use the regular standard precaution PPE during use. Thanks, Curtis. Next slide. Safety-wise, there was a couple of papers written by Gotchamanis in the 80s and early 90s that were published in the Australian Dental Association journal, and that was trying to flag safety concerns about the strength of the fluoride. But the reality is that the average lethal dose by oral administration is 520 milligrams per kilo. Each drop of the silver fluoride contains 9.5 milligrams of silver diamine fluoride and is enough to use on 5 teeth or 5 lesions. Assuming the smallest child with caries would be in the range of 10 kilos, the recommendation to limit use to 1 drop per treatment visit has an extremely wide safety margin, and no significant adverse effects from fluoride toxicity have ever been reported. Thanks, Curtis. Next slide. The main contraindications are on patients with a silver allergy, and it's not effective on teeth that have already had a pulpal involvement. So those would be the main recommendations of when not to use this product. Children with stomatitis and ulcerative gingival conditions will probably experience more of a burning sensation, which is why we recommend not to use it in areas where there's a lot of inflammation or ulceration in the gingival region. The main adverse effects are the staining component of the product. So if it gets on skin, or if you would not want it to drop in the white of someone's eyes, or even plastics and bench tops, it stains serious clothing. Like that stain is not coming out. The recommendation, if you're using the Riva Star product, is to put the green capsule straight on top of any spills to try and help reduce the staining, but basically try really hard not to get it anywhere other than the tooth surface. Thanks, Curtis. Next slide. So the conversation about consent, I think in dentistry we're moving towards simplified language a lot to make sure that everybody understands what we're talking about. And this checklist was provided as a recommended conversation in one of the references that I'll include at the end of the presentation. And it's very, very, very plain language so that parents understand what to expect. So feel free to take a screenshot of this slide if you like, but it is with the pictures in one of the articles that I've referenced at the end of the presentation. And you can see the color change here. Often takes a couple of days to change color after application of the silver fluoride onto the carious lesions. Thanks, Curtis. Next slide. This paper I really liked, which basically investigated parental perceptions of the use of silver fluoride. And the main finding was that parents were much more accepting of staining on posterior teeth, but they will accept staining on anterior teeth when they're warned of all the risks associated with some of our stronger and pharmaceutical behavior management options like general anesthetic. So this is an important part of the conversation before referring for a GA as well, that there are, like Dan was saying, there are other options for preventing the hospitalizations, which is safer. Thanks, Curtis. Next slide. This is part of the American Dental Association's recommendations on non-carious cavity control. And you can see basically any type of lesion, if it's cavitated, the recommendation is to use silver diamine fluoride for management. Thanks, Curtis. Next slide. So the recommended procedure is to remove any plaque or debris with either a toothbrush or gauze or a spoon excavator, whatever you can use to empty the cavity of anything that's in there. But you don't need to remove the caries itself, just debris, plaque, food, stuff like that. It is recommended that you use a gingival barrier, which can be Vaseline or a caulking agent like Oraseal, or there is a barrier provided that comes with the Revastar kit. Frankly, I've never used any gingival barriers, and I haven't had any problems with kids having an experience of discomfort on the gingiva. That's mainly what it's for. So we isolate the area with suction or cotton rolls or gauze, whatever you need, and apply the colorless liquid using a microbrush. And I generally, even though I know that the cavity is still going to turn black after adding the potassium iodide, I like to apply the potassium iodide if the child will tolerate it afterwards, because it helps me. There is a precipitate formed, and it helps see where the silver fluoride extended to initially, so that can be helpful. And then sometimes I'll use an MI varnish afterwards, because it distracts the child from the taste of the bitterness of the taste. And then you want to keep a close eye on these lesions to make sure that they stay arrested and hard and dark, indicating that the lesion has arrested. Thanks, Curtis. This is all my favorite references. And if you read all of these, you should feel pretty confident about the product and its use. There's also a number of excellent YouTube videos. This is one of them that outlines and demonstrates use in a child. So have a bit of a search around YouTube, because there's plenty on there. And final slide, thanks, Curtis. In summary, silver diamine fluoride is preferable to conventional restorative treatment for a number of reasons. One is that it's very much easier to use on children than the provision of a conventional restoration. It's cheap and easy. It's conservative because caries removal is unnecessary. Buys time for familiarization if you're dealing with a really young child, and it's safer than the provision of a GA. If we can avoid a GA by stabilizing lesions, then that's what we want to do. So I hope I'll be able to answer any questions that you might have following Ruth's presentation. And over to you, Ruth.
Thanks, Katie. So now that we've seen the second part of the puzzle, which is stabilization of disease, I fill in the third part of the puzzle, which is in terms of managing the child patient who does need care beyond perhaps stabilization, and who does need care beyond stabilization. So my area is, which I'll be talking about, is relative analgesia, or nitrous, as we like to call it for short. And looking at alternatives to GA, where nitrous is an option used in the public and the private system, and DHSV is wanting to increase the state's access to relative analgesia. And these are for a variety of reasons. Good reasons. One of them, it supports timely, better local care to patients, and this is this will be very important in regional areas, I imagine, where the trip to the dental hospital is a long journey. A second bonus is that it would upskill clinicians, so giving them a new skill set where they're able to treat difficult patients at a primary care level. And the third one is to break that cycle of patients just expecting to have all their oral care needs to be solved by GA. And we know that doesn't work in the long run. When I've worked in GA myself treating children, I find that parents come in with their children to have a GA, and the next time we see them, even though we've tried to give preventative advice, they come in again after a year or 6 months for the next GA and just think that that's normal. And this is part of breaking the cycle of GAs. They're not great to recover from. I'm not sure if any of you have had a GA. I have had a couple, and there's a lot of recovery time as well post-GA. So what RA does, or nitrous, is reduces the dependence on GA as the only alternative for someone who can't be treated in the chair. The dental conditions are one of the highest of the 22 types of preventable hospitalization. So here, this is our part as public dental service to help address that. And interestingly, even though so many patients actually request a GA, a study was done that found that 70% of those GA patients, when experiencing RA, actually found it much more acceptable. And RA also helps, when it keeps things local, it helps that the oral health messages stay at the primary health setting where they know the clinician, as opposed to visiting a specialist for a one-off and then coming back. It's an opportunity to build that relationship and actually help move towards better overall healthcare. And patients report that they actually prefer having treatment in their dental home, whether it's a metro agency or a regional agency. It's the area they know, and I guess they have built relationships there, or have the opportunity to. So the option for nitrous allows us to provide a wider range of care through the state, not just RDH, not looking at RDH as the one place that can do this. We're trying to build capacity through the state. So there's been an expression of interest sent through to all CDAs to apply for funding for a nitrous machine and a nitrous training course, and with that is specialist supervision for your first 10 cases. So you will have a specialist, it is remote supervision, who will be able to support you. So you're not on there on your own. You do have someone helping you out. Next slide, please, Curtis. So what does nitrous do? I've talked about a couple of things: increase in the clinician skill set, and this is a skill set that you might even be able to transfer to a private practice if you worked in a private practice as well, or later on in life. There's all these skills we build along the way that'll help us in our professional journey. It's not just restricted to kids, because if you think about it, you've got these particular adult patients that are just a little bit difficult to treat in the chair, extremely nervous. So nitrous can be used for them as well. It can be used for people with a strong gag reflex. They're not necessarily scared, but that tongue just doesn't let you get good isolation, or they flick off rubber dam clamps. So this can help reduce the gag reflex. Hypersensitive first molars, those ones you can't touch even though you've given all the LA you can. Nitrous can be the answer to that. And also when we really try to fix something and the child's moving and or even the adult's moving and there's saliva all over the place, here's a chance, and we try to do this herodontic, so we actually have something in there. We can look at silver diamond fluoride as one option, as Katie has educated us on today. And another one is to actually, if we want to do more, if we have to do more restorative dentistry, this could be another option. Thanks, Curtis. We talked about what nitrous is good for. I'll just put a little note for what nitrous is unsuitable for. So very high level special needs or anxious, because we can't actually do a checkup or a radiograph. They can't wear a dental mask. These sort of people are that subset that would look at requiring GA. Extensive treatment. If someone has a lot of, it's a real broken down dentition, then that might be something that is discussed with the pedo department in terms of how much should be managed as GA, how much should be managed maybe within the pedo department, and then ultimately though, the aim is to get the patient back for regular care within their home clinic. And of course, if you're unable to breathe through your nose, that would be a barrier for GA. Thanks, Curtis. I think that's the end. So that's a little snapshot of the offer that is available for all clinicians, the NITRIS program. I'd encourage you, if you haven't heard of it already, to speak to your manager who would have got the mail out, and discuss within the clinic and your clinician, your clinical team, if that is something that would be right for you, if something that's clinicians are eager to do, and put in the application. It's the machine is provided, there is no cost to the organization, and so this is a great opportunity to start a new practice in your clinic. So what we will do is move on to questions in a minute. I encourage you to see this as an opportunity to interact with the specialist, and this is one of our aims through the Clinician Forum, to help CDA clinicians and engage them to work with the dental hospital, and the dental hospital to work with the CDA. So we actually form one great big public health service, rather than all these little satellites all over independently working, doing great things, but not necessarily learning how we can all do things better. So we've got Daniel here to answer all the PEDS questions you ever wanted to ask. We've got Katie here to clarify anything to do with silver diamond fluoride, and I can help out if you have any details about NITRIS. So without much ado, I'll turn it over to question time. Thanks, Claire will be moderating. Sorry, Claire Lynn is on the line moderating our question time.
Thanks, Ruth. We've got a few questions coming in. I know that some of our presenters have already provided some typed responses, but we do have a bit of time, so I might just run through them. The first, which Katie's just put a response up to, is whether upon prescription by a dental practitioner, can a cert for DA with fluoride component apply SDF? So Katie's response there, at the moment, DAs, even with cert 4, are not able to apply SDF, so it's limited to DTs, OHTs and DHs. The next question, and I might hand it over to you, Dan, once I've read it out, just to provide some commentary on it. So on a posterior deciduous tooth with interproximal caries, should we be using silver fluoride or a stainless steel crown Hall technique, or does it not make a difference with long-term outcome? So Dan.
Yeah, there's actually quite a bit to that question. I should have probably made some notes while I was thinking about it to cover them all. So the benefits of the crown is it's a bit more definitive than silver diamine fluoride in terms of it restores contour, function. It's an easier shape to clean. It's less likely to get recurrent caries if you've closed it up completely. If the parent or the child's habits slip back, which is unfortunately common. There is stronger evidence for the use of a Hall technique crown published. So in terms of what we've got for long-term success. However, if we're looking at dental hospital guidelines, international guidelines, really ideally, the ideal situation is we have bite wings for assessing if a tooth is suitable for Hall crowns for when you've got deep or large lesions. And if you can't get bite wings, then SDF's a great alternative option as an interim to slow down and arrest the lesion, build some confidence in the child, hopefully get the bite wings, hopefully put a stainless steel crown on. And SDF is also faster, quicker as well. So just that child who's 3 or 4, you think that probably when in 6 months or 12 months that you can probably get a Hall crown on that tooth. Great option to just arrest it and slow it in the interim. As Katie also said, with SDF, you need an open cavity. So if you're looking at, just small interproximal lesions, then SDF is probably not going to be very effective. So getting a Hall crown on would be better in that situation.
Thanks, Dan, and thanks to those comments around this as well. So there's some advising that Creighton's formulary has a better acceptance because it's water-based, so you don't have that ammonia smell. And another comment about applying Vaseline to the lips at the beginning for SDF use, just to prevent lip tattooing. So thanks for those comments. Another question. Oh, sorry, Dan.
Sorry, I'll just add with the Vaseline, it's probably worth also, the SDF is a bit, I'm trying to think of the right word, caustic to the tissues. So, doing that Vaseline protection for lips is actually quite a good idea for that as well. It's a similar idea as using the gingival barrier if needed.
Great, thanks. So a couple more questions coming through around sedation and sedatives, which Ruth or others feel free to jump in. Do many clinicians use oral sedatives?
I have used oral sedatives in terms of, say, temazepam or diazepam with adult patients, and that is in consultation with their GP. So if someone is very nervous, we do talk about that option, but we do talk about it in conjunction with their GP. And there have been patients where the GP has, there have been cases where the GP has agreed that this would be a good alternative going forward, and it has worked. But my experience has been with adult patients.
With pediatrics, generally not really, because you can usually get just as good a result out of nitrous oxide, which is a quicker, safer option than most oral sedative options. So Midaz would be a common one, and it also is just in terms of equipment required, particularly emergency equipment required for over-sedation, recovery time, and you can't use multiple sedation techniques without having a specific sedationist. So if you're bringing in an oral sedation and then multiple oral sedations or medications, or you're using oral sedation and a nitrous oxide, you're breaching the anaesthetic guidelines without having a sedationist specifically. So generally, it's nitrous oxide works for the vast majority of kids. Otherwise, they're not going to get, the oral sedation is not going to be any more effective.
Great, thank you. Now, another one on nitrous oxide and the offer to CDAs. Ruth, will the clinicians be supported for accreditation training, and will the relevant ARPA recognised sedation training be provided? So
with the offer that went out, there was information that's saying there is an accredited DHSV run course on nitrous oxide conscious sedation, and this is run 4 times a year at the Royal Dental Hospital. And there is an expectation that the clinician wanting to do conscious sedation will be attending this course to be able to perform conscious sedation. And what will happen is that after doing the course, when they start their first cases, there will be, as I said, supervision for the first 10 cases to ensure that they're supported.
Another question on nitrous, can DTs or OHTs be trained to use it?
It's outside the scope as set by the dental board on my for sedation.
And I think a question for you, Katie, in regards to SDF, is one application usually enough, and what would be your review period?
Ideally twice a year, but not necessarily. I don't think there's any evidence to support that more than twice a year makes any difference. But one thing I probably didn't put enough emphasis on in my presentation was that this is a lesion stabilization. It's not disease stabilization. So it also requires disease management to keep that lesion arrested. So behavior modification, diet change, change in plot control techniques. Otherwise, the same as you would continue to get secondary caries around the margin of a restoration, the lesion will continue to break down if those aspects of disease control are not managed.
Thanks, Katie. If anyone else has any other questions, feel free to type them in. I can't see any at the moment, but Katie, I might just ask you one other one that I'm interested in as well. With SDF, I understand that if there's pulpal involvement, you mentioned, that would be a contraindication. Does that refer to any level of symptoms, so, you know, cold sensitivity or reversible pulpitis, or is it more extensive pulpal involvement?
Good question. Probably if there was irreversible pulpal symptoms. Yeah, it's a very good liner under a temporary restoration if there's any chance that pulp could be saved by lesion management. I like using it, and it doesn't affect the bonding of GIC or composite resin. Good for root caries and root sensitivity more broadly as well, but just, yeah, it won't save a tooth if the tooth is already past it, if you know what I mean. Yeah.
Okay, great. There's another question that's come through. If we are part of a hospital, are we still required to have all the emergency equipment, such as the pulse oximeter, defibrillator, in the clinic for doing nitrous? So maybe for Ruth or Dan there.
I would say yes, because, well, it depends on which hospital you're specifically talking about. But you would be best off to have things like a pulse oximeter to be able to alert you to a problem early rather than late. So pulse oximetry is one of the biggest safety pieces of equipment that's made general anaesthesia much safer over the last 50 years. So defibrillator is probably less important to have just there on hand, especially if because if you're in a hospital, I would expect that the emergency team would bring one. But you should have a separate portable oxygen source and relevant airway equipment available for over-sedation.
Okay, thank you. Any other questions? I can't see any. If the team has noticed any I've missed, please feel free to address them. But I can't see any new questions at the moment. I might ask one more of Katie and just see whether any flicks in. In your experience with silver fluoride, do kids usually find it comfortable? Do they complain about it? Dan or Katie, I suppose.
I've never had any adults or children complain about use of silver fluoride, and obviously very careful to manage their expectations about the color change of the lesion, but symptom-wise, zero. In my experience. I don't know about Dan.
I've only ever had one, and that's because I'm pretty sure that it was an interproximal lesions, and I reckon a tiny little bit got on the gingiva, and they got irritated by it. So that's where making sure you've got protection and keeping it off soft tissues is really important.
Great, thanks. Another question around off-label use of SDF as a karyostatic agent and whether the TGA is being approached to legalise its use in Australia. I'm not sure if we have the answer to that one. Does anyone?
I think the question is it okay to use off-label? And I was part of the fluoride update of the fluoride guidelines, and I think we've moved on past that because it's now referenced as a caries arresting agent in the guideline for fluoride use in Australia. Another comment, the SDI product is also being an aqueous formulation is being developed by the SDI company, so I'm not sure if it's on the market yet, but that may change the way we use it. They're still keen to use potassium iodide, but it won't be that high, that high pH that may be a bit caustic on the tissues. The other thing I think I wanted to say was that with one application of silver diamine fluoride, you get something like about 60 to 70% rates of arresting. On the second one, it jumps quite high up to 86% from memory success of arresting. So even with one, you get quite a good response, but with 2 it jumps to another level. So two applications over a 12-month period is recommended.
I see there's another question come up from regarding special needs patients, but I've got someone ask me how young, and this is for you, Dan, how young is too young for nitrous sedation?
Basically, they have to be able to cooperate enough to breathe through the mask while you're doing your work. The dental hospital sort of puts as a guideline 2 years as the youngest, which is if you get someone younger than 2 years to be able to cooperate for long enough for you to breathe through the mask and do the procedure, good luck, probably anyway. But certainly 3-year-olds can do it quite well. So, you know, taking out 4 upper incisors on a 3-year-old under nitrous sedation is quite routine, unfortunately, but definitely highly acceptable method of doing it.
Thanks.
And we've got another question on nitrous. If the dentist is trained in the use of nitrous oxide, does the DA need to be qualified also? As part of a previous course this person attended, they mentioned only the dentist needs to be qualified. And is there a requirement for nitrous to always have an extra DA for the session? So Dan or Ruth probably.
So the legal requirement set out by PSO 9, which is the anaesthetic guidelines, is only the dentist needs to be trained. However, it's prudent for safety that the DA knows what they're doing to make sure they know how all the equipment works in terms of setup and all that sort of thing. But also the DA can assist in an emergency situation as well. It is also recommended that there is another DA available in terms of monitoring, but also legally 2 people need to be with a patient the whole time. So if the DA needed to step out of the room or the clinical space to grab any extra equipment or anything because it wasn't set up or there was a change in the plan, that's not permissible. So that you'd need to have someone who could grab that extra equipment, as an example.
Thanks, Dan. Are there any ongoing costs for RA machine maintenance? Ruth?
Yes, so there would be ongoing costs, including, say, gas cylinders, servicing of equipment, and of course the continual training and refresher courses in nitrous or basic life support. So this would be the responsibility of the agency. However, the initial cost of setting up all the equipment, which is a larger cost, that would be funded by DHSV.
Great. Team, have I missed any questions that have come through? I can't see any others at this point. So if that's the case, if there's no other questions, I may hand back over to Martin to tie us up, but do feel free to type any questions ongoing and we can respond to them after the event too.
Thank you, Claire. Well moderated, and I think we can congratulate everybody on a fairly smooth production, and I'm happy to say that, and also I think it'll just get more smoother as we continue. I want to say thank you to you all for responding to the feedback that we sent out last time. I think I'll talk to Maggie, but I think we'll send out something again just to check how it went. So be prepared for another feedback survey. I think we'll do that. We'll also we'll type up the questions and we'll send them out to you as a document. I think I'll also I think I'll also send out the latest fluoride guidelines. I think that would be something you could refer to when you feel a bit unsure about the off-label, that there's something more official. So look, in summing up, I'd like to thank Daniel for his description and clarification around the referral process into the specialist unit. And I think we can note that there's more than one way to manage a child, and that the general anaesthetics is something to be avoided. I also compliment him on the follow-up process, because it's always been I guess a criticism that we do the general anaesthetic and then we either never see the child again, or they come back as a return. Even worse scenarios, they come back as another GA. So I think the follow-up with the prevention is really commendable. Katie, thank you for explaining how cheap, safe and easy silver diamine fluoride is. And I also I think it has multiple uses, but in this context, it's enabling us to stabilize the child in a atraumatic way before a more definitive care can be provided, but also it provides that time to work on the prevention with the parents, to look at diet, brushing, and I think the fact that parents will accept the staining even on the anterior teeth if that's a choice between stained teeth and a general anaesthetic, and I think that highlights our duty of care to reduce the number of general anaesthetics as well. With the access to the nitrous oxide machines, I checked with the people who hold the money in this situation, and I think if you've got a case for getting the nitrous oxide, it doesn't have to be all about children. I would also consider the special needs component of care. So don't feel like you just have to be, if you're not sending many children in for GA, but you may have more people you're sending in for special needs that could be managed with the nitrous oxide. So that's about it for me. Thank you, team, and thank you, Curtis, for your behind the scenes support, and Maggie for the coordination. If you do have a burning question, either you can send it in through to me directly, or either one of the Coho team, or through your art doors, they're called now. So thank you once again, and we finished on time, this even before time. So according to the feedback, there was a desire to have these somewhere between 4 and 6 weeks, 4 and 8 weeks rather. So we're sort of settled on 6 weeks, but if there's a special topic that comes up, we can bring that forward if something comes up. So I'll sign off now. Thank you, team. Thank you, everybody, and we'll see you in 6 weeks' time with another topic. All right, goodbye.